Okay, students, I'm going to continue with the focus on the post-operative care as a continuation of the lecture today. So we briefly talked about this particular slide. Um, when I talked about receiving a report from the anesthesia personnel, that assessment in the immediate post-operative recovery facility always includes respiratory, cardiac, neurological, dressings, drains, and surgical sites, pain management, and renal function. So the patient's recovery is first handled in the post anesthesia care unit, also known as the PACU. Nursing care includes all of the things I mentioned, the three things, the respiratory, cardiovascular, all of those things. In addition, there will be temperature, gastrointestinal, and urinary problems may have to be addressed, but the surgical wound is always going to be the primary focus. Care of the patient following surgery again begins as the patient enters the PACU. Now, the PACU, as I said earlier, is typically found adjacent to the operating room to minimize transportation time. This close proximity also provides the patient and the PACU staff with immediate access to anesthesia and the OR staff while that patient is recovering. The primary goal of nursing care in the PACU is to monitor the patient for complications of anesthesia and the surgical procedure. So immediately post-op in nursing care, we have nursing interventions. We want to maintain a patent airway through positioning, suctioning, and care of an ET tube if there's one in place. Um, Fluid replacement and blood administration if necessary. Pain management through administration of that medication. So what they will do in the PACU as your patient is recovering is encourage them to deep breathe and move the patient until they regain consciousness. So, if they had some type of intramuscular blocking agent, adjunct to the general anesthesia, while in the post anesthesia care unit, you should report anything, but anything that is not that's going to affect their respiratory. So I talked about this. A weak chest movement means that it could lead to hypoxemia. Nausea, lethargy, and disorientation are possible adverse effects of anesthetic drugs, but they are not as great of a concern as respiratory depression. So you're always monitoring their respiratory status. The other thing is that they may have had inhaled anesthesia. I talked a little bit about TIVA earlier. There's a possibility of complications with inhaled anesthetics, and they're going to include coughing, laryngospasms, and increased secretions. So it is a possible complication of inhalation is going to include those laryngospasms. That's very important to recognize. Um, Following surgery, and they're in that PACU that's adjacent to the operating room. They are monitored very, very closely there. It's the PACU's nurse is the the goal is to get them from the PACU either as an outpatient, if it's an outpatient surgery, back to to be able to be transported to home or the nursing facility, or they're going to transfer them to the unit. Either way, they're going to give a report. They always give SBAR, and they always take a last set of vital signs. Post anesthesia care is divided into three phases: phase one, phase two, and extended observation. So, phase one, phase two, extended observation is going to occur. Phase one, this is the initial recovery period. Basic life sustaining needs are the highest priority, of course. Most patients are prone to complications, pardon me, and require constant vigilance. So the patient might require management of an artificial airway. They're going to have continuous EKG monitoring so that they can monitor them for changes in heart rate that might affect or indicate basically that your patient has some pain, some anxiety, or some bleeding, hypovolemia, or some abnormal electrolytes, even. So they do frequent blood pressure monitoring. Frequently, they're going to assess circulation, including body temperature, cap refill, skin color, and moisture. Frequently, they're going to assess their neurologic system. We want to know what their level of consciousness is, their orientation, their sensory and motor status, and their pupils. So they are vigilant in assessment in the PACU in phase one. The other thing is that if their saturations are dropping, say it's 89% and they're unconscious, and they were transferred from surgery to PACU about 15 or 20 minutes ago, the first action that you will find for unconscious patients is to perform a jaw thrust maneuver. You learn the jaw thrust maneuver with CPR. So, by possibly their airway being obstructed by the tongue, the first action is to clear the airway by maneuvers such as that jaw thrust or chin lift. That is very important. So the goal of phase one is to prepare the patient for phase two or the inpatient unit. So it's important, very important, to manage the patient that has received any anesthesia. It is very, very important to be specific about your documentation as well. Um, you're checking out all of their signs and symptoms based on system. That is very important. What must you get when the patient is being transferred? Again, get a set of baseline set of vitals. Airway is very important. Breathing is very indicative of possible fluid overload or if they're aspirating. Temperature, body temperature is very important to note as well because of malignant hyperthermia. Assessment of the urinary system focuses on intake, output, and fluid balance. So, inoperative fluid totals are part of the anesthesia report. So, therefore, you should be very mindful of the presence of all intravenous lines, all irrigation solutions, infusions, and all output devices such as catheters and wound drains. So, postoperative orders related to incision care are instituted at this time. All data obtained in the admission assessment are documented on that PACU report. And this is a form specific to post anesthesia and post surgical care. GU assessment focuses on intake and output influence and fluid balance. Intake includes intraoperative fluids as reported by the nurse anesthetist or the anesthesia care provider. Output includes catheters and wound drains. You know from Maslow's airway, breathing, circulation is very important. Um, Disability and exposure is also in there when you look at ABCDE. Neurologic, GI, GU, surgical site, and pain are critical for care in the PACU. So after the initial assessment, we continue to apply the skills of the nursing process. Atelectasis, we're always concerned with the lungs in the PACU, and as a matter of fact, any unit that they're going to. Gastrointestinal assessment includes bowel sounds, your NG tube placement and drainage, and subjective reports of nausea. So, the purpose of an NG tube is to decompress. So, that's important for you to understand as well. So that surgical site is going to be assessed for type and condition of the dressing and presence of drainage and things like that. Laboratory and diagnostic tests are important and have to be carried out as ordered. So here I'm showing you post-operative complications that can occur. And oftentimes with post-operative complications, one of the biggest things that we see is DVTs. So there are potential complications, of course, that's going to affect airway obstruction. Hypoxemia, atelectasis, and pulmonary edema are other complications. So I'm giving you basically a review of systems, as you can see here, that shows aspiration and bronchospasms, several other things, hypoventilation. So, airway obstruction is commonly caused by the patient's tongue and is most pronounced when supine or extremely sleepy. Hypoxemia, this is partial pressure of the arterial oxygen that's less than 60 millimeters of mercury, and it's characterized by signs and symptoms including agitation, uh, hypertension to hypotension, tachycardia to bradycardia. The pulse oxes are usually much lower than 90%. Atelectasis is the most common cause of hypoxemia. It's caused by retention of basic secretions and a decrease in respiratory excursion, or it could be due to general anesthesia. Your pulmonary edema, this is big because it's caused by the accumulation of fluid in the alveoli. It may be the result of fluid overload, heart failure, prolonged airway obstruction, sepsis, or aspiration. Now, if they aspirate gastric contents into the lungs, this might cause laryngospasms, infection, and pulmonary edema. And these are potentially serious emergent situations. So what we want to do is in the PACU is that we are taking vital signs every 15 minutes. A slight drop in postoperative blood pressure is within a normal pulse, and they're having a warm, dry skin indicates a normal response to the residual effects of the anesthesia and requires only ongoing monitoring. But we will, in the PACU, continue to take vital signs every 15 minutes in the PACU. Again, take vital signs about every 15 minutes. Pain control for acute pain is important. Follows up with acute injury, disease, and surgery. Monitor those vital signs very closely. Check that surgical site and make sure if there's any shadowing on the dressing, take an indelible pen and mark the shadowing area just to make sure they're not eviscerating or dehisced or anything bleeding. Uh, bleeding out of that or having complications out of that site. So, the other surgical complication that I'm showing you here is called paralytic ileus. This is a temporary stoppage of peristalsis due to the manipulation of the intestines during surgery. It could be that they're treated with an NG tube for the paralytic ileus, so there's be insertion, maintenance, removal, and assessment that has to occur with that. The common causes of respiratory problems for postoperative patients in the clinical unit are atelectasis and pneumonia, especially after abdominal and thoracic surgery. The patient should initially be positioned in the lateral recovery position to keep the airway open and avoid aspiration. So, in the PACU, nursing interventions are designed to prevent and treat respiratory problems. Proper positioning of the patient to facilitate respirations and protect that airway is essential. So it reduces the risk of aspiration and keeps that airway open. Once conscious, the patient is usually returned to a supine position with the head of the bed elevated. This position maximizes expansion of the thorax by decreasing the pressure of the abdominal contents on the diaphragm. So we place the patient in a lateral recovery position until conscious. Reposition to supine once conscious to maximize expansion of the thorax. Deep breathing is encouraged to facilitate that gas exchange and to promote the return to consciousness. So once the patient is more awake, deep breathing and coughing techniques help the patient prevent alveolar collapse and move respiratory secretions to larger airway passages for expectoration. So, we've talked about these complications respiratory wise. So, for nursing care, assess those lung sounds, IPPA, cough and deep breathe. Turn them every 2 hours. Incentive spirometer in ambulation will help to prevent any type of complications respiratory wise. Effective coughing is essential in mobilizing those secretions. You should change the patient's position every 1 or 2 hours to allow for full chest expansion and to increase perfusion of both lungs. Sitting in a chair in ambulation should be aggressively carried out as soon as the physician approval is given. Remember, some of these patients in recovery in the PACU are going to be going home, and some will be going to the unit. So, of course, changing that position. The other thing is that, let's just say, uh, for example, your patient's blood pressure in the PACU drops from the admission blood pressure from a 140 over 86 to a 102 over 60. Let's just say it was that, with a pulse change of 70 to 96 beats per minute. Let's just say their saturations are 92% on 3 liters of oxygen. There is an order in the PACU of how these PACU nurses will respond to these situations. The first action should be to increase that IV fluid rate because the most common cause of hypotension is volume loss. So the IV rate should be increased. And in the PACU, that's what they will do. The next action would be to increase that oxygen flow rate to maximize oxygenation of hypoperfused organs. And because hemorrhage is a common cause of postoperative volume loss, the nurse should check the dressing next. Finally, the last thing that you want to do is assess the temperature to determine the effects of vasodilation caused by rewarming. So, first, the first thing you're going to do based on their blood pressure dropping systolically 140 to 102 and their pulse rate changing from 70 to 96 beats per minute is that the first thing is you would increase the IV infusion rate. Next, you would increase the oxygen flow rate. The next thing you would do is assess that patient's dressing, and the last thing you would do is check on the patient's temperature in that order. Patients most at risk for cardiovascular complications are those with alterations of respiratory function, persons with a history of cardiovascular disease, of course, and older adults, and debilitated and critically ill individuals. So hypotension is seen in the hypoperfusion to vital organs, including the brain, heart, and kidneys. The clinical signs may include disorientation, loss of consciousness, chest pain, and oliguria. The most common cause of hypotension in the PACU are unreplaced fluid and blood loss. So, cardiac dysfunction is decreased systemically with vascular resistance. Of course, you learned that from your previous courses. Dysrhythmias, drugs, and measurement errors, or taking a blood pressure with an incorrectly sized cuff, may also cause hypotension. Hypertension, commonly the result of the SNS stimulation caused by pain or anxiety, bladder distension, respiratory distress, hypothermia, or some pre existing hypertension. So you have all of these things that you see on the screen uh, that could occur. We could talk about a venous thrombotic emboli as well, syncope, or where people are beginning to feel faint. All of these things can occur. So fluid overload and edema can occur when IV fluids are administered too quickly. So, especially when chronic diseases exist like cardiac or renal or in older adults. So, we make recommendations for diuretic medications. Electrolyte imbalances, hypokalemia, results from urinary and gastrointestinal tract losses and can affect contractility of the heart as well as result in decreased cardiac output and tissue perfusion. So, PACU, vital signs monitoring every 15 minutes in phase one. Compare them with preoperative and intraoperative to determine if those vital signs are returning to baseline. You will call the surgeon if any of the following occurs. Their systolic blood pressure is less than 90 or greater than 160. Their pulse rate is less than 60 or greater than 120. Their pulse pressure, the difference between the systolic and the diastolic blood pressure, narrows. Their blood pressure trends gradually decrease or increase over several consecutive readings. If there's a change in the heart rhythm, and if there's significant deviation from the preoperative readings. Um, Now, hypotension is normal pulse, and warm and dry skin is usually related to residual vasodilating, and that's the effects of the anesthesia. And so that needs to be continued to be observed. Um, Hypotension with rapid or weak pulse or cold or clammy pale skin may indicate impending hypovolemic shock, and that is going to require immediate attention. So, we're going to assess for hypo and hypertension. IV fluid boluses may have to be given to normalize that blood pressure. And so these are the things that I want you to, as a PACU nurse, to be very cognizant of and understand the interventions you will have to perform for cardiac and fluid electrolyte complications. Early ambulation, venous thrombosis, thrombotic emboli, prophylaxis, STDs, things like that. These are interventions to prevent cardiovascular and urinary complications. So we want to monitor their urine output, have a working knowledge of that type of procedure, and if renal ischemia or cardiovascular compromise could occur. IV fluids are ordered. They may be the result of fluid loss in the OR or GI loss. So if the patient remains NPO, they will require hydration support. Monitor their output with a Foley if clinically indicated. If not, we're going to be removing that Foley as soon as possible to prevent catheter associated infections and the patient's ability to initiate voiding. If able, place the patient in a normal positioning for voiding. For males, this may mean that they're standing up or sitting on the commode versus a bedpan to pass urine. If urine output is absent or low, A non invasive measure would be to bladder scan and to determine if the patient had urine retention. If indicated, the patient may require being straight cath until the return of the ability to initiate voiding. Early ambulation to increase that muscle tone, stimulate circulation, and prevent venous stasis or VTEs. The VTE prophylaxis is recommended for patients with multiple risk factors for VTEs that are, non-ambulatory, or they had a previous history of a VTE. So they might get a low molecular heparin, weight heparin. They, put on SCDs, and slow positioning changes may prevent any type of syncope with the patient. Hypothermia, loss of heat from prolonged operating room time, cool IV fluids, loss of bodily fluids, dry gases, elderly, debilitated, intoxicated, they're all at high risk. DVTs, stress and immobility, body positioning, anything that promotes venous stasis increases clotting tendencies. So early ambulation increases that muscle tone, stimulates circulation, and prevents venous stasis and VTEs. Again, VTE prophylaxis is recommended for patients with multiple risk factors for VTE. You're non ambulatory or having a previous history of a VTE. Again, we're going to give them some kind of heparin, sequential devices. Slow positioning changes may prevent syncope. We've talked about that. Other postoperative complications, that can occur is nausea and vomiting. And when we have these complications due to medications or something like that, we have to be prepared to give them medications to prevent them from vomiting and having nausea. There are two types of postoperative cognitive impairment, things that are seen in surgical patients. One is called postoperative cognitive dysfunction, which is known as POCD, and the other one is delirium. So, POCD is a decline in cognitive function, like memory, ability to concentrate, for like weeks and months after the surgery. Postoperative delirium is also more common in older patients, but it can occur at any age. Anxiety and depression may also occur in postoperative patients. And alcohol withdrawal delirium occurs as a result of alcohol withdrawal in postoperative patients. And they begin to hallucinate, have visual hallucinations, restlessness, and things like that. Patients are unconscious during surgery, so we know oftentimes that opioids are given for pain management and neuromuscular blocking agents may be given to prevent patient movement on that operating table. So these medications need to clear from the patient's system for return of baseline neurologic function and mobility status. Emergent delirium may be a result of the type of anesthesia used. Could be the result of hypoxia, bladder distension, pain, or residual neuromuscular blockage. This too is more commonly seen in older adults. Delayed emergence may result from prolonged action of opioids and sedatives and residuals from neuromuscular block agents and inhaled agents too. So, all of this is important information when you're dealing with your potential neurologic problems. So we know hypoxemia is a strong contributor to confusion and delirium. So we have a continuous pulse ox and oxygen therapy should be applied. We want to maintain patient safety with the use of side rails, securing that equipment such as IVs and artificial airways, and monitoring their physiologic status. So, having the call bell available for them and using two patient identifiers before giving drugs or completing any treatment. Pain, of course, we're aware of what happens with pain. Adequate nutrition is very important. Alcohol protocols may be needed to be initiated if withdrawal is suspected. Alcohol withdrawal may present as agitation, confusion, and irritability. Electrolyte imbalances should be corrected, as this can also manifest as confusion or irritation. Bowel and bladder function should be assessed. The need to pass the bowel or urinate without the ability to do so may contribute to irritation and agitation. If the patient is confused, special attention must be placed on patient safety, and that is important to do. So, we're going to monitor mobility status and activity status for safety. You should discuss the patient's expectations regarding activity and assistance needed following discharge. The patient and the caregiver must be included in the discharge planning and provided with information and support to make an informed decision about continuing care. Um, One of the things that you see here is deep visceral pain. Pain, as you know, it can be very, very dangerous. And so there has to be a plan for pain control that includes behavioral modalities, and control of anxiety is developed preoperatively. So, of course, if there's going to be a PCA, like a patient controlled analgesic, a regional or local anesthetic, it has to be used, that has to be used postoperatively. That modality should be discussed with the patient. The other thing is that deep visceral pain is a signal for complications. So it can contribute to complications and delay the return to normal gastric function. And so that's going to increase the risk of atelectasis and impaired respiratory function. Postoperative pain relief is the responsibility, is the nurse's responsibility, because the surgeon's orders for analgesic medication and other comfort measures are usually written on an as needed or a PRN basis. For some surgical patients, like orthopedic patients that you will be taking care of, some of you will be on an ortho floor, warmed IV fluids can be used. Postoperatively, these patients demonstrate higher core temperatures, a decrease in shivering, and shorter recovery times. Shivering can increase oxygen consumption, carbon dioxide production, and cardiac output, as well as significantly affect the patient's comfort level. Um, so, shivering can increase resting energy expenditure as well. We see that shivering can contribute to that increased heart rate, that increase in blood pressure, or intracranial pressure as well, and is significantly will affect the patient's comfort level. I've talked about malignant hyperthermia or MH, which causes a rapid rise in that core body temperature. to 105 degrees Fahrenheit or more or higher. And they will have severe muscle contractions as well as tachycardia, hypercarbia, metabolic and respiratory acidosis, myoglobin binuria, and elevated creatinine kinase levels after receiving general anesthesia. It's a life threatening complication that most often occurs during general anesthesia, but it may also be seen in the 1 hour period immediately following surgery. So this can happen in the PACU. The fast track programs are used to facilitate patient recovery, and they're specific to each surgical procedure. So by using this rapid PACU progression, um, the patient progresses rapidly through phase 1 to phase 2. So these fast tracking involves moving those OR direct patients directly to phase 2, which is what we typically see in ambulatory surgery. The goals of fast tracking or rapid progression include cutting the cost and increasing patient satisfaction, decreasing overall recovery time, length of hospital stay, and a decrease in morbidity. So when we look at this, we have something called the modified Aldrete scoring system, which takes into consideration the patient's consciousness, their activity level, their respirations, oxygenation, and circulation status. And they have a score of 9 to 10 indicating readiness for transfer. All right. And so before sending that patient to phase 2 care areas, the patient should have a return to neurologic baseline. So they're aware of the situation, oriented, able to follow commands. They must be hemodynamically stable. Their blood pressure and heart rate are baseline or close to baseline without anticipating changes. That surgical site should have minimal drainage, and the pain should be managed with a continued plan for further management. So, nurse to nurse communication is going to be essential from phase 1 to phase 2. We use SBAR to do that. You all understand how that works. Um, and, we know that nausea and vomiting has to be controlled because postoperatively, nausea and vomiting remain the most common postoperative complication. Nausea and vomiting remain the most common postoperative complication. GI problems are responsible for unanticipated hospital admission of day surgery patients. Increased patient discomfort, delays in discharge, and patient dissatisfaction with surgical experiences. We find this with our GI problems. Abdominal distension is another common problem caused by decreased peristalsis. Peristalsis, as you know, is having that motion in the ocean, like things are moving along, waving right along in the abdominal area. This can occur if there is a problem because of decreased peristalsis as a result of handling of the intestines during surgery and because they have limited dietary intake before and after surgery. Hiccups are an intermittent spasm of the diaphragm caused by irritation of that phrenic nerve that innervates the diaphragm. So a lot of our patients come out with hiccups. Early ambulation with paralytic ileus. It's important to get people moving so that they can increase the peristalsis and blood flow as well. So we assess for the return of bowel function and increased mobility. It tends to be the better option. Um, Although there is some limited evidence regarding early ambulation and decreased abdominal distension, it is still the standard post-operative intervention. So early ambulation to prevent paralytic iliasis, and decreased abdominal distension by assessing for bowel sounds in all four quadrants. MPO until that bowel sound returns and they have a gag reflex, and they will start out with a clear liquid diet. You would not start them out on anything too heavy for them because you don't want to have that problem. So, care should be taken to prevent aspiration. If the patient vomits while still sleepy from anesthesia, you want to protect that patient from aspiration by positioning the patient in the lateral recovery position. And also, guys, have suction equipment readily available at the bedside. So, if you know you're getting that patient, make sure you have all of this equipment there. All right. So it's important. It's very, very important. These patients come back and they're going to have a low urine output for probably the first 24 hours after surgery. It's expected, by the second or third day, the patient will begin to have increasing urine output after fluid has been mobilized and the immediate stress reaction subsides. So we're not too excited if they don't uh, pass urine for 6 to 8 hours after surgery. All right, so as I said, they're going to have a decreased urine output. It may be expected that first 24 hours because of increased aldosterone and the ADH secretion. Um, you guys should remember about the renin, angiotensin, aldosterone system. Um, and most patients urinate 6 to 8 hours after surgery. If they don't, we're going to bladder scan them and see what's going on. Oliguria could be due to renal ischemia or altered cardiovascular status, will also affect urine output. So it should be investigated if urine output remains abnormal. Catheter associated urinary tract infections, also known as CAUTIs, is a risk, and therefore the catheter should be removed as soon as possible. You can facilitate voiding by normal positioning of the patient, sitting for women and standing for men. Surgeons often leave in order to catheterize the patient in 6 to 8 hours if voiding has not occurred. All right, so that's we're just going to monitor that urine output and have knowledge, a working knowledge that is, of the type and procedure that they had done, and if renal ischemia or cardiovascular compromise could have occurred. So you bladder scan and straight cath per the orders. In typically surgical patients, it's there already. They already placed that order in there. Wound infection may result from contamination of the wound from three major sources. It's either exogenous flora present in the environment on the skin, oral flora, or intestinal flora. Surgical dressings should initially be changed by the physician. However, if there is shadowing or drainage, you should mark it or mark that area with that surgical marker and to ensure that that drainage is not excessive. So you're going to watch the surgical dressing very, very closely, but you will not cover it with like an ABD pad or anything like that. Leave it open, just monitor it by marking it with a surgical marker to see if the amount of drainage changes. Um, Here, I've talked about wound dehiscence or the separation and disruption of a previously joint wound. Uh, it may be preceded by a sudden discharge of brown or pink or clear drainage. So wound dehiscence is important. A lot of people, if say they had a mastectomy and they have all of a sudden they hear a pop and they feel really wet, that wound may have dehisced. And that is something that is very, very important for you to react on. You have got to intervene. The other thing is evisceration. Evisceration, and their intestines or something starts spilling out of the abdomen. The one thing you will do is not push on that to try to put it back in or anything like that. You cover it with a sterile towel and with some sterile normal saline and get some help in there on that dressing. So when we're looking at all of this, nursing implementation or intervention, when drainage occurs, you have to note the type, the amount, the color, the consistency, and the odor. Avoid dislodging any of those drains and maintain a glycemic control. Talk to them about deep breathing and coughing to prevent those fevers. So this is why we have them use that incentive spirometer frequently to prevent pulmonary stasis. Post-op care of the incision, healing depends on the location of the incision, the type of closure. Is it through, it's a primary intention from surgical patients. So it should heal fairly well and not develop much infection. Nutritional status, we want to know what their albumin levels are. If they have the presence of disease, infection, drains, and dressings, that could affect healing, especially if they're a diabetic and things like that. Wound infection does not occur as soon as you leave the PACU post-operatively. There's the area is cold and bacteria is not present. So wound infection usually occurs 36 to 48 hours post-op, and to about 5 to 7 days. Predisposing factors, I have them listed here for you. You can read through them. They explain themselves. If there is a breach in a septic technique, yes, of course, that is a predisposing factor to the non-healing surgical wound. Of course, for interventions to prevent pain and discomfort, I'm showing you here that the patients may have an epidural for for pain reasons. The other thing that's very common that you will see on the units is a PCA pump. Once again, the visceral pain may signal some kind of complications, such as hypovolemia or bleeding of some sort. So patient teaching regarding how to report that pain is very, very important, and you will intervene if there is pain or discomfort. Here I'm showing you some surgical drains. The top picture is an NG tube. As nurses, you will sink NG tubes. NG tubes basically decompress the stomach area. T tubes are very common drains for bowel duct drainage. It sort of like has a consistency and a thickness of motor oil. You guys know what a Foley catheter looks like. That bulb that you see in the picture is a Jackson Pratt, and it removes drainage from the operative site. So the expected outcome of using the NG tube is gastrointestinal tract depression. Ambulatory surgery may also be referred to as same day surgery. The patients come to the OR and they have a surgical procedure completed and progresses to discharge readiness in the same day. So the patient may have received general or regional anesthesia and they might be admitted directly to phase two. Remember, this is also called fast tracking phase two, and it accounts for about 70% of surgeries performed here in the United States. And basically, your patients will be fast tracked so that they can return to their homes or wherever they are going to. The patient leaving an ambulatory setting must be mobile and alert to provide a degree of self care when discharged to home. Postoperative pain and nausea and vomiting must be controlled. And overall, the patient must be stable and near the level of preoperative functioning for discharge from that unit. At discharge, teaching specific to the type of anesthesia received and the surgery is provided to the patient and caregiver, and it is reinforced with written instructions. The patient may not drive. They must be accompanied by a responsible adult at the time of discharge. The patient leaving the ambulatory surgical setting must be near preoperative level of functioning. If the patient goes home with home health, they should be assessed by the nurse to ensure they are doing activities that will prevent them from returning to the hospital. We always discuss pneumonia with the patients at home in their activities. And again, a responsible adult must be present to transport the patient from the PACU. So, post-operative teaching is provided. We do the post anesthesia scoring system, which is very similar to that modified Aldrete scoring system that they mention in your textbook. The preparation for the patient's discharge should be an ongoing process throughout that surgical experience that begins during that preoperative period. So they are informed. As the time of discharge approaches, be certain that the patient and any caregivers have the following information: care of the incision and any dressings, including bathing requirements or recommendations, action and possible side effects of any drugs, when and how to take them, activities allowed and prohibited, when various activities can be resumed safely, such as driving a car, returning to work, sexual intercourse, and leisure activities, and also dietary restrictions or modifications. Symptoms to be reported are going to include fever, increased incisional drainage, unrelieved incisional pain, discomfort, and any other parts of the body if they have any discomfort, where and when to return for follow up care, and answers to any individual questions or concerns. So, discharge home, diet and exercise, pain control, care of that surgical site, post op surgeon visits, and what problems could develop and what to do if those problems develop have to be discussed. Okay, students, this ends this portion of the lecture. Peace is costly, but it is worth the expense. Have a good evening.